Welcome, everybody. If everybody can come take your seats. Wow. I am delighted to see all of you here for our first grand rounds of the season for the Department of Medicine. I appreciate everybody coming. And particularly appreciate the residents for coming and being here. We've changed our process for grand rounds this year a bit. So we are going to have one in-person grand rounds a month with a special invited outside speaker. The other grand rounds will be virtual. So we really hope people come in person once a month for this. We've also extended, we have an additional session immediately following grand rounds for informal question and answer and discussion with our outside speakers. So for the in-person grand rounds, if you have time afterwards, and if there's additional questions you want to meet with our speakers, please stay around. So first, a little message from Laura Zakowski, our Vice Chair for Education, who is overseeing grand rounds.
Thank you. I have a few thank yous to make. There's another couple of transitions in grand rounds. First is Clint Thayer, who's been behind the scenes in keeping the technology working before, during, and after the pandemic. 17 years and probably 15,000 grand rounds. Thank you, Clint. And Esther Schulman, who's sitting in the back of the room, she ensures that Grand Rounds is accredited for CME, so we can all get CME credit, and make sure everything in the logistics in the room is going well. Thank you, Esther. And the reason for these thank yous is also because we're moving to a new person, Catherine Vaughn, who's sitting next to Clint here. Catherine, thank you for being here. Catherine is our continuing education specialist, and she comes here after many years of teaching and coordinating curriculum and directing and doing all things education. So we're very excited to have her here to hopefully fill the shoes of Esther and Clint, a little bit of both. So thank you very much. And I'll turn this over to Dr. Schnapp.
Great. Thank you. Thank you, Laura. So to introduce today's guest speaker, we have Dr. Natasha Martins, who is one of our newest faculty, shared with the Department of Population Health, and delighted to have Natasha come and do the introductions.
Thank you, Dr. Schnapp. Yeah, so hi, I'm Natasha Merton, Assistant Professor in the Population Health Sciences Department and the Department of Medicine and the Division of Geriatrics to complete the full affiliation so people can place me for next time maybe. So it's my pleasure today to introduce my colleague and friend, Dr. Barcu Darst, as the kickoff speaker for the Department of Medicine Grand Rounds 2023-2024 lecture series. Dr. Darst is currently an assistant professor at the Fred Hutchinson Cancer Center at UW, another UW, in Seattle. Prior to this position, she completed her postdoc at the University of Southern California Cancer Center for Genetic Epidemiology and Department of Population and Public Health Sciences. And Barcu is also a previous UW graduate. She did her PhD in epidemiology with a minor in computation and informatics and genomics, and a graduate certificate in bioinformatics here at SMPH at UW Madison, which is where I met her for the first time in 2017. Dr. Darst's research is focused on identifying and understanding genetic and multi-omic risk factors of prostate cancer in diverse populations. She has extensive experience in genetic epidemiology as well as genetic association and metabolomic investigations. And she has done previous research to integrate genomic and metabolomic data to understand the complex underlying mechanisms contributing to complex aging diseases such as Alzheimer's disease. Currently, she is leading an effort to improve the understanding of the genomic and metabolomic mechanisms contributing to prostate cancer risk in men from diverse populations, as well as improving the utility of polygenetic risk scores and rare genetic variants for the prediction of prostate cancer across patient populations. And this is what she's going to tell us about today, I hope. So I'm excited for learning more in that about that new research that she's doing. Her research is funded by the NIH, and she also received multiple other distinguished awards, including the Prostate Cancer Foundation Young Investigator Award and the ACCR Next Gen Star Award. Barcu is not only an outstanding researcher, but also a great teacher, and as soon you will also realize a very, very good speaker. So please join me in welcoming Dr. Darst. Yeah.
Thanks, Natasha. Can everyone hear me okay? All right. Thank you so much for that really nice introduction, and to organizers of Grand Rounds for inviting me to be the kickoff speaker for this year. It's really exciting to be back in Madison again, and just even driving here from the hotel was a beautiful drive along the water, and getting to see more of campus and all the familiar places that I used to go to was really just nice to reminisce on my really nice time being here as a grad student. So today I'm going to talk to you about the potential for genetics to reduce prostate cancer health disparities. So I have no disclosures to report. The main three objectives that I really want to convey during this talk today are describing how genetic risk factors for prostate cancer are not diagnostic, but could inform future risk of disease development. The second is to demonstrate how genetics could inform when to initiate prostate cancer screening and how frequently screening should occur. And the last is just to give you a little bit of familiarity with some of the genetic factors that increase risk of aggressive prostate cancer, particularly in African ancestry men, where we see greatest risk of prostate cancer. So prostate cancer is one of the most commonly diagnosed cancers and a leading cause of cancer death in men in the US. And it also represents one of the biggest health disparities in the US today. So these two figures here are showing incident rate ratios on the left and mortality rate ratios on the right over the past 2 decades. And if you just look on the left figure first, you can see that these rate ratios are shown across the diverse population shown here, and they're each relative to white men, shown by the black horizontal line. So you can see that Black or African American men have had incidence rates that are about 50 to 75% higher than white men. When we look at mortality rates, we see even greater disparities, where Black men have had mortality rates that are 2 to 2.5 times higher than they are in white men. And this has been very persistent and consistent across the last 2 decades. Despite being a very common cancer and a leading cause of cancer death, there are very few established risk factors for prostate cancer. Some of these include age, population, as shown in these two figures, and family history or germline genetics, with the heritability of prostate cancer being estimated to be about 58%. And this actually makes prostate cancer one of the most heritable cancers, so it has a very strong genetic contribution. And indeed, when we look across all the genetic studies that have been conducted, at least as of 2021, when this review was published, you can see that across the genome, there are many regions that are very strongly associated with prostate cancer risk. So this figure here is showing each of the 23 chromosomes in the genome, and annotated in the very small little dots next to each chromosome is a particular region of that chromosome where there has been some evidence of association with prostate cancer risk. And this figure is showing both common variants and rare variants. And it's also indicating regions where there's some evidence of association between the variant and disease aggressiveness. Another thing that this figure highlights is that evidence for association with more aggressive risk has been more commonly observed in rare variants than common variants. And some examples of genes you may have heard of that contain rare variants associated with prostate cancer risk are BRCA2 and ATM. Usually people are familiar with these because they're associated with breast cancer risk, but they're also really big risk factors for prostate cancer. And that's not really as commonly known as we know for breast cancer, but they're very important risk factors. So despite having a very strong genetic contribution and knowing that prostate cancer has a really big health disparity, there's been a lack of diversity in genetic studies over the last couple decades since large-scale genetic studies have been done that could potentially contribute to health disparities. So here in this figure, it's showing the distribution of participants by their genetic ancestry that have contributed to genetic association studies. And you can see in red that European ancestry individuals have been predominantly represented by genetic association studies. However, this is not at all reflective of the global diversity, where we see that only about 12% or so of the global population is European ancestry. So European ancestry individuals are really overrepresented in genetic studies. And consequently, when we develop polygenic models of disease risk or try to use genetics to inform disease risk, you can see that the predictive ability of these models is increasingly poor in populations that are more ancestrally distant from European ancestry. And in particular, we usually see the lowest predictive ability for these polygenic models in African ancestry individuals. You can imagine, in conjunction with existing health disparities, for example, what we see in prostate cancer, that if we use these models that have really poor predictive ability in African ancestry individuals, that could potentially exacerbate existing health disparities. So in prostate cancer, we're really aware of this problem, and it's a really hard problem to overcome, but we try to incorporate as much genetic information from African ancestry participants and other non-European ancestry populations as we can, so that our models are more generalizable and more applicable beyond European ancestry individuals. So I'm going to talk predominantly about 3 different topics today during this talk. First, I'll talk about some work that we've done to construct a multi-ancestry polygenic risk score. Then I'll talk about some genetic risk variants for prostate cancer that are population specific, so only found in one population. And last, I'll talk about some work that we've done to combine polygenic risk scores and rare genetic variants to get a more comprehensive assessment of risk of prostate cancer. And the overarching goal that I'd like to convey is that inherited genetic risk factors inform future risk of prostate cancer across diverse populations and could potentially be used to improve risk stratified prostate cancer screening and reduce prostate cancer health disparities. So first, I'll talk about polygenic risk scores, or PRS. So a couple years ago, we conducted a large and diverse prostate cancer genome-wide association study, which we refer to as a GWAS study. It included over 230,000 men across the population shown here. And we tested the association between 17 million genetic variants and prostate cancer risk, testing each of these variants one at a time for association with prostate cancer risk. So the results from that are shown in this figure here, which is referred to as a Manhattan plot. On the x-axis, we have the chromosome, the different chromosomes of the genome. And on the y-axis, we have the -log10 p-value. So each dot represents the association between a particular genetic variant, for instance, this variant in chromosome 2, and prostate cancer risk. And the red horizontal line represents our significance threshold. So you can see there are many regions throughout the genome that are very strongly associated with prostate cancer risk. From this study, we identified 86 novel risk variants that hadn't been previously associated with prostate cancer risk. We identified for 62 known regions, we were able to identify stronger markers of risk in those regions using a multi-ancestry fine mapping approach. And I won't talk too much about fine mapping, but just briefly, it's a statistical approach we use to try to identify a variant in a region that's more likely to be causally associated with prostate cancer. And then for 121 other known prostate cancer risk variants, they remain the lead signal in their region based on our analysis. So in total, this brought the number of known prostate cancer variants to 269. In aggregate, these 269 variants account for about 34 to about 43% of the familial relative risk of prostate cancer, which really just means that if we were able to account for all of the variation due to genetics, it would be 100%. But right now, we're able to account for about 34 to 43% just using these 269 variants alone. So there's more variation that we haven't yet accounted for, but we're doing a pretty good job of identifying the genetic contribution to prostate cancer. So next, we took these 269 variants and used them to construct a polygenic risk score, or a PRS. So a polygenic risk score, it's really a pretty simple calculation. It's just a weighted sum of the number of risk alleles carried by a given participant. So in this equation, G represents the number of risk alleles for a given variant in a given individual. Beta represents a multi-ancestry weight for that specific variant. And we sum up this number across the 269 variants to get a single polygenic risk score, just one number for each participant. And this number indicates their genetic predisposition to prostate cancer. So once we have this calculated across all of our participants, it's a continuous variable. So we can plot it, we can plot the PRS here to see what the distribution of the polygenic risk scores is in cases, here shown in the solid line, and in control shown in the dotted line. And you can see that the distribution is a little bit right shifted. It's a little higher in cases than controls, which we expect to see if the polygenic risk score is doing what we hope for it to be doing. So the way that we like to analyze this polygenic risk score is to stratify our participants into deciles, and we determine those PRS decile cutoffs using the distribution of the PRS in controls as shown here. We then compare the number of cases and controls in each decile, for instance, in the 90 to 100% decile versus the average 40 to 60% PRS category. And we do this for each decile to get an odds ratio for each of the deciles. So we did this in a large independent sample of over 500,000 men from different studies and different populations, but many of them were from the Million Veteran Program. We then calculate the odds ratio for each of the PRS deciles, again, using the 40 to 60% category as our reference category. And you can see that the odds ratios we observe across the different populations in studies are really pretty similar. They're not too widely different between the different populations and studies, which is showing that we have pretty good replication and gives us more confidence in the ability of our polygenic risk score to predict prostate cancer risk. If we combine across the broad populations and just meta-analyze those summary stats that we showed in the previous slide, you can see that the odds ratios range from about 2.8 in African ancestry men up to 3.8 in European ancestry men. So this is showing that the polygenic risk score works pretty well, and it actually has really good predictive ability across diverse populations. It is a little bit lower in African ancestry men, so there's certainly some room for improvement, but an odds ratio of 3 is still very potentially clinically meaningful. So we're doing a pretty good job with our polygenic risk score. There's a few other ways that we evaluated our polygenic risk score to just better understand how could this be used in a clinical setting. One thing that we did was to stratify our participants by age and recalculate the association between the polygenic risk score and prostate cancer risk. And you can see that in European and in African ancestry men that we see larger odds of prostate cancer among the younger participants. And we see smaller odds as the participants get older, indicated by the pink color here. So this is suggesting that the PRS would likely be most informative of prostate cancer risk in men who are less than 55 or so years of age, which makes sense because the older a man is, the more time he's had to accumulate environmental risk factors that could potentially influence his prostate cancer risk. Whereas if a man is diagnosed with prostate cancer at a younger age, it's more likely to have a stronger genetic component. Another thing we did, sorry, this figure looks a little bit different than it's supposed to here, but we also looked at the association between the polygenic risk score and age at diagnosis. So this is just looking within men who have prostate cancer. And you can see on the x-axis, we have the PRS category. On the y-axis, we have mean age at diagnosis. If we look just within one population to start, for instance, East Asian men, so shown in blue, you can see that the higher the polygenic risk score, the younger the mean age at diagnosis. And this is true across all the populations that we look at, suggesting that the polygenic risk score could potentially be informative for what age might be ideal to start screening for prostate cancer. You'll also note in this figure that it looks like there's differences in age at diagnosis between the different populations, but this is really just reflecting differences in sampling strategies for the study design rather than true differences in age at diagnosis. Another thing we did was to look at absolute risk of prostate cancer by age and PRS category. So here we're showing absolute risk of prostate cancer on the y-axis. On the x-axis, we're showing age. And the different colored lines represent the different polygenic risk score categories. So you can see that the higher the polygenic risk score, the higher the absolute risk of prostate cancer. And there's a pretty notable difference here by different PRS categories of seeing a really high absolute risk. I've also annotated onto these figures this 5% absolute risk threshold and average lifetime absolute risk in each of the populations, which slightly differs since they do have different risks. But you'll notice that if we look at men, for instance, European ancestry men who are in the top PRS decile, they have an age they reach this 5% absolute risk threshold about 12 years earlier than European ancestry men with average genetic risk. We see pretty similar differences when we look at African and Hispanic men as well. So this is just further showing that we could really use these polygenic risk scores to inform what is the best age to start prostate cancer screening. And then we also look at these absolute risk measurements incorporating family history information into it. And you can see it's a really similar picture to what we previously showed. But now you can see that across the different PRS categories, men who are family history positive have a higher absolute risk of prostate cancer, which is suggesting that the combination of family history and polygenic risk scores is likely optimally informative of prostate cancer risk than just one or the other. An important question to address as prostate cancer is whether you can identify men who are at risk of aggressive disease. So we look to see how men with aggressive disease are distributed across the different PRS categories. So here the PRS categories are shown on the y-axis. And you can see in European ancestry men, looking at the bright green, that there's about 50% of men with aggressive tumors fall into the top PRS quintile, the 80 to 100% PRS categories. Likewise, in African ancestry men, about 45% of men with aggressive tumors fall in the top PRS quintile, which is suggesting that the PRS would likely be able to identify a large proportion of aggressive cases if it were used in the clinical setting. Another way that we address this question is to look at the association between the polygenic risk score and different categories of disease aggressiveness. So here we're showing the odds ratios for different categories of disease aggressiveness relative to controls. And if you compare, for instance, this pink one here, which is showing the odds ratio for aggressive versus non-aggressive disease, aggressive versus control, to this teal one here, which is non-aggressive versus control, you can see there is this significant effect heterogeneity where there's larger risk of aggressive disease than we see for non-aggressive disease. And to more directly address this question, we also just looked at the odds ratio for metastatic disease versus non-aggressive disease. And you can see that men in the top PRS decile have 65% higher odds of metastatic versus non-aggressive disease. And one of the most important things to note about this particular finding is that this is looking at a pretty large sample of African ancestry men. When we look at other populations, we don't often see the PRS being able to distinguish between disease aggressiveness. So this is something that so far has seemed fairly unique to African ancestry men, but is still really promising because African ancestry men have the highest risk of prostate cancer. So we really want to be able to identify those men who have aggressive disease or risk of aggressive disease. So another study was done a couple years ago that had some pretty interesting results. They looked at our polygenic risk score of 269 variants in a cohort of men who are on active surveillance. They found that the higher PRS was associated, significantly associated with risk of converting from active surveillance to treatment. So men who are initially diagnosed with localized disease are often recommended to go on an active surveillance protocol, where instead of receiving treatment, they'll see their physician fairly often to have their PSA measured, do a digital rectal exam, and have biopsies to see if their prostate cancer is changing or progressing and they indeed need to receive treatment. There's a lot of reasons why a man might switch from active surveillance to treatment. The thought here is that this could be indicating that there's some risk of disease progression, but men may also switch to treatment just because there's some anxiety about knowing you have prostate cancer and not treating it. They may also just tire of being on this really intensive active surveillance protocol instead of just receiving treatment and trying to be done with it. So we wanted to more directly ask this question: is the polygenic risk score associated with risk of progression or disease upgrading? So we did this in the Canary Pass study, the prostate cancer active surveillance study, where we have about 1,200 men who have genetic data and have been followed on this active surveillance protocol for about 20 years. And you can see, looking at this figure, this shows the diversity of our participants with different populations shown by different colors. We do have a fairly diverse population, but about 85% of them are non-Hispanic white men. So it is still mostly not terribly diverse, but we do conduct our analyses in the most inclusive way that we can so that our results can be as generalizable as possible based on this data set. But we do see that each standard deviation unit increase in the polygenic risk score is associated with 26% increased risk of grade reclassification among these men who are on active surveillance, which is suggesting that potentially we could use genetic information to better maybe fine-tune a man's active surveillance protocol where they have more or less intensive screening based on their genetic information. And that could really have important implications for their quality of life. Because we do have really nice phenotypic data in PASS, we also look at the association between the polygenic risk score and the ratio of positive cores. And we saw that a higher PRS was associated with higher ratio of positive cores, which could indicate that there's some tumor multifocality or that the tumor is showing up in multiple spots on the prostate. We also see an association between higher PRS and smaller prostate size and higher PSA density, both of which have been suggested to be associated with more aggressive disease in some previous studies. So this paper is still in progress, but we're hoping to be able to submit it pretty soon. So to kind of think about how much improvement we see from adding more diverse participants to our GWAS studies and to the development of polygenic risk scores, I kind of wanted to summarize what we did in 2021 versus what previously existed in terms of GWAS studies for prostate cancer. So in 2018, there had been about 80,000 cases included in GWAS studies, and they were mostly all of European ancestry. And these studies led to the identification of 180 variants that were used to construct a polygenic risk score. In 2021, we added about 30,000 cases, almost all of which were non-European ancestry men, and also a large number of controls that were non-European ancestry men. And from that, we identified these 269 variants, and you can see that the new PRS we have leads to significantly improved performance of the polygenic risk score compared to what we previously developed for mostly European ancestry men. So we are seeing a pretty substantial improvement just from including more diversity into our studies. And more recently, we completed analysis, a new GWAS study that has over 900,000 men, including a large number of non-European ancestry men, which led to the identification of 451 variants associated with prostate cancer risk and a new polygenic risk score that shows some improvement. I'm not leading that work, so I'm not going to talk too much more about it for today, but we do see with this bigger GWAS that there's some improvement in the polygenic risk score. So the last question that I want to address with polygenic risk scores is the potential for a genome-wide polygenic risk score to improve prostate cancer. So to this point, we've been talking about genome-wide significant polygenic risk scores, which means that we're only including variants that have statistical evidence of being associated with prostate cancer risk. But recently, there's been a lot of studies that suggest that a genome-wide approach where you include variants across the genome, whether or not they're associated with the disease of interest, could potentially could lead to improved predictive ability. For instance, they see this a lot in cardiovascular disease, where these genome-wide polygenic risk scores have much better predictive ability than a genome-wide significant PRS. So we wanted to see what's the best approach that we should be using in prostate cancer. So we conducted this study using the results from the GWAS that we conducted in 2021. And we constructed 6 different genome-wide polygenic risk scores using the different algorithms shown here, the names of which are in bold. Again, the input to these were the summary stats from the GWAS summary statistics from the 2021 paper, and we include 1.1 million variants from this HapMap3 panel. And these are variants that are fairly common across many populations, and they're just recommended to be used by these different approaches, which is why we chose to use them. But it's 1 million variants as opposed to just 269 in our much smaller, carefully created polygenic risk score. Once we had all of these polygenic risk scores constructed, we tested them in an independent testing data set that included African and European ancestry men. And then we did additional independent validation in African and European ancestry men from the Million Veteran Program. And we evaluate the PRS by looking at the area under the curve, or AUC, and also looking at the odds of prostate cancer based on the PRS. So first, just looking at our validation data, the Million Veteran Program, African ancestry men, we have over 6,000 cases and 53,000 controls of African ancestry, where we're now testing the different polygenic risk scores that we constructed. So here in this figure, we're showing the AUC for a covariate-only model. So this just has age and genetic ancestry in the model. But when we add our polygenic risk score of 269 variants, you can see that there's a huge improvement in the AUC. We also see improvement for the genome-wide approaches, which are shown by the different colored dots here, but they're not as substantial as what we observed for our 269 variant. We see a significantly higher AUC for our PRS versus the genome-wide approaches. And likewise, when we look at odds of prostate cancer, we see that the odds ratio is much larger for our 269 PRS compared to all of the different genome-wide approaches. Next, looking at the validation European ancestry data from Million Veteran Program, here there's about 13,000 cases and 200,000 controls. We see a really similar figure as what we previously did, but now you can see that this one particular approach, PRS-CSX, for genome-wide polygenic risk scores, has pretty similar AUC and odds ratio of what we observed for our 269, but it's not better, and ours only has 269 variants. So if you're to implement this in a clinical setting, it's much easier to genotype 269 variants than it is 1 million variants. So overall, our results suggest that a genome-wide polygenic risk score did not improve the prediction of prostate cancer risk. And this is really important because if we were to use these in a clinical setting, we want to make sure that the PRS we're using is really the optimal one that we should be using. So to kind of think about all the things we've talked about for polygenic risk scores, could PRS reduce prostate cancer disparities, and how could it if so? So in this figure that we showed earlier, we showed that age could potentially, or that the PRS could potentially inform the age at which men should start screening and how frequently they should receive that screening thereafter. We see this, this potential for improving screening age at initiation in both European and African ancestry men and in Hispanic men as well, which is not shown right now. We also show that the PRS may be able to identify African ancestry men who have increased risk of lethal disease, since we did see that, particularly in African ancestry men, the PRS was associated with aggressive versus non-aggressive disease. But I think an important next step for polygenic risk scores in general and for this work is to really improve and increase the number of non-European ancestry men who are included in these studies so that we can see further improvements in our polygenic risk scores. So next I'll talk about population-specific genetic variants associated with prostate cancer risk. And I'm going to give you 2 examples of these types of variants. So one is from, is based on this paper that was conducted a few years ago, where they conducted a genome-wide association study that included about 20,000 African ancestry men. The strongest signal that they identified was this particular variant in the 8q24, it's on chromosome 8. That had a really large odds of prostate cancer. So usually in GWAS studies, the associations we identify have odds ratios that are maybe 1.1 or 1.2, but here we're seeing 2.3. So this is a really large odds ratio for a single genetic variant. Also, this variant is fairly common. It's carried by 11% of African ancestry men. Although this particular variant is a non-coding intergenic variant, there is some evidence that it lies in a prostate cancer specific enhancer, so it could have some functional relevance to the biology of prostate cancer. So we wanted to follow up on this variant to better understand its association with prostate cancer risk. And in this subsequent paper, we found that the risk allele for this variant was more common in men who had a stronger family history of prostate cancer and in those who were diagnosed at younger ages. We also found that this risk allele was increasingly common in men with more aggressive disease, with an odds ratio of 2.7 for lethal disease in men who carried just 1 copy, and an odds ratio of 8 for men who carried 2 copies of the risk allele. We also looked at how much familial relative risk could be explained by this one particular variant in African ancestry men. And you can see that the familial relative risk for this one variant is about 9%. To give you an idea of how much that is, at the time, there were 180 known prostate cancer variants, which in aggregate accounted for about 30% of the variation. So this one variant is accounting for about 30% of what we could account for at the time, which is pretty huge for a single variant. When we look at the risk allele frequency of this variant by global African ancestry, you can see that it's increasingly common in men with more global African ancestry. So this is really just going to show that this variant truly is African ancestry specific, and it's a large prostate cancer risk variant that we wouldn't be able to identify in other populations. We also looked at how this variant was distributed across different African ancestry populations. And you can see there's a pretty wide range in frequencies, all the way down from 2.5 in Akoli men from Uganda, up to 15% in men from the Democratic Republic of the Congo. If we look just within North America, there's a little bit less variation, but it ranges from about 4 to 8%. So there is a pretty wide amount of variation of how common this variant is across different African ancestry populations. And then last, we again look at absolute risk of prostate cancer, similar to what we showed before, but now the different colored lines are showing different carrier statuses. So gray is men who carry no copies of the allele, blue is men who carry 1 copy, and then red is men who carry 2 copies of the risk allele. And if we just focus on family history positive absolute risk, which is shown by the dotted line, you can see that the absolute risk of prostate cancer by age 60 is about 9% in family history positive men who carry no copies of the risk allele. That goes up to 21% in men who carry 1 copy of the risk allele, and 38% in men who carry 2. An absolute risk of 38% by age 60 for prostate cancer is pretty huge. So definitely this variant could be very informative for prostate cancer risk stratified screening. The highest absolute risk that we observed was about 80% by age 85 in men who carry 2 copies and are family history positive. And we also see that the absolute risk in men who are family history negative but carry 1 copy of the risk allele is about the same as men who are family history positive and carry no copies of allele. So this is really just going to show that this particular variant is providing a lot of additional information beyond what's usually captured by family history, and could be very informative for risk stratified screening. So we know that this variant is a really important risk factor for aggressive prostate cancer in African ancestry men. How can we actually incorporate it into risk stratified screening? A rare European ancestry specific variant that's in the HOXB13 gene, which accounts for about 5% familial relative risk, as opposed to the 9% we see for a HOXB13 variant. Men who carry this rare HOXB13 variant are recommended to consider starting screening at the age 40 or 10 years before the youngest family diagnosis in their family. So similar guidelines for our 8q24 variant could prove really beneficial for African ancestry men. So the second example that I'll give of a population-specific risk variant is in the HOXB13 gene. So talking a little bit more about that particular gene. This is a pretty established prostate cancer risk gene, mostly because of the European ancestry variant that was discovered a few years ago and is really well known. This variant is really thought to be a Scandinavian variant. It's only found in populations with Scandinavian ancestry. But some of the less commonly known variants in HOXB13 that are also associated with prostate cancer risk are this particular variant that's only found in Japanese populations, and this variant that's only found in Chinese populations. And more recently, there was a variant that was found to only be in African ancestry populations based on this study here, where they did exome sequencing of HOXB13 in 46 early onset prostate cancer cases. They identified 3 men who were carrying this particular variant, and this variant is a stop loss deletion, so it potentially could have some really important functional relevance for prostate cancer, but it's exceedingly rare. The allele frequency is 0.2%. So this study, it was a case-only study, and it was pretty small. They couldn't actually do any association testing to see if it's really associated with prostate cancer risk. So we thought we would follow up on this variant and see if we could use our large-scale African ancestry genetic data sets to try to see if it's actually associated with risk of prostate cancer. But since this is a really rare variant, it's not captured on our genotyping platform. So we instead try to genetically impute it using the data that we have. So we do this using two different genetic reference imputation panels. One is called 1,000 Genomes, where there's about 2,500 participants, 3 of which are carriers of this really rare variant. And one is the TopMed reference imputation panel, which has about 97,000 participants, 126 of which carry this really rare variant. Here I'm showing the info scores, which indicates how good the imputation quality was based on these two different imputation panels. And this ranges from 0 to 1, with 1 being perfect imputation quality. So you can see these are pretty decent. It's about 0.7 to 0.8, so that's not bad. But in TopMed, we see really good imputation quality of 0.9 or higher. But when we compare the men who are identified to be carriers using these two different imputation panels, they're perfectly discordant. So we needed to figure out which of them is actually indicating the correct information. So we did confirmatory genotyping in a set of about 1,500 men, prioritizing the men who are identified to be carriers in using either of these imputation panels. And we found that the carriers identified by 1,000 Genomes were not actually carriers when we did confirmatory genotyping, but almost all of the carriers identified by TopMed imputation were carriers. So this is really just to emphasize that it's really important to have these diverse, large reference imputation panels if we want to be able to study these really rare variants that are, especially if they're population-specific rare variants. So once we felt confident about the variant that we're able to call now, we did some follow-up analyses to see if it's actually associated with prostate cancer risk. And you can see overall that carrying 1 copy of this HOXP13 variant is associated with 2.4 odds increased risk of prostate cancer. When we look at more aggressive disease risk, you can see that there's a higher odds for more aggressive disease risk, both based on Gleason and stage and metastatic disease, which is where we see the largest odds. So men carrying 1 copy of this risk allele have 5.1 increased odds of metastatic prostate cancer. So this is a risk factor for a more aggressive disease in African ancestry men. The last thing that we did that we thought was really interesting was to see what's the genetic ancestry of the men who are carrying these particular variants. So we had a pretty diverse sample of men from different regions of Africa. And when we look at the genetic ancestry of these men, which is shown by this figure here, you can see that most of the men, or all of the men who are carriers, which is indicated by the little black spots and the black triangles on this plot, they all have some amount of West African ancestry. It wasn't found at all in men who were from South Africa, East Africa, or North Africa. So this is suggesting not only is this African ancestry specific, but it's West African ancestry specific, which is really important in the US because a lot of Black and African American men in the US have a lot of West African ancestry. So this could be a fairly common, at least somewhat more common in African American men. So how could population-specific variants potentially reduce prostate cancer disparities? To help us think about that, I posted here the NCCN guidelines, which is a lot to read, but I tried to highlight the parts that I really want you to take away. So these are the guidelines for early prostate cancer detection, specifically regarding germline genetics. And here they recommend that men who carry rare pathogenic variants in BRCA2 start screening at age 40, and that they continue screening annually after that. And they also recommend that men who carry rare germline variants and other genes that they list in this in the guidelines consider shared decision-making for prostate cancer and start at age 40 also. So these recommendations are really very specific to rare pathogenic variants, but we've shown in our research that there's some common variants that are important for risk of aggressive disease, particularly in African ancestry men. So expanding these guidelines to more broadly encompass the amount of evidence that we have would potentially be really helpful for reducing prostate cancer disparities. Another thing I just want to point out is that within these guidelines, they do have some discussion around HOXP13, but they only talk about the European ancestry variant. They don't mention the other variants that are present in other populations. And the European Ancestry one has no evidence of association with aggressive disease. So it's kind of questionable how useful it is to screen those men to begin with. But our HOXB13 variant in West African men does have evidence of association with aggressive disease. So the last thing that I'll briefly talk about is some work we've done to combine polygenic risk scores and rare genetic variants. So we've touched on this briefly, but I'll just say a little bit more that there is some good evidence that rare variants are important for risk of aggressive disease. In this paper that was just accepted at JAMA Oncology, we did exome sequencing in about 17,000 prostate cancer cases. About half were aggressive and half were non-aggressive. And for the genes shown here, we do see pretty strong evidence of association between rare pathogenic variants in these genes and disease aggressiveness. And in particular, we see BRCA2 and ATM showing up as important genes. This is looking in a sample of European ancestry men, but there's been some work in African ancestry men that also shows that rare pathogenic variants, particularly in these genes here, are important for disease aggressiveness. So we conducted this study to ask the question, is the impact of these rare pathogenic variants potentially modified by a polygenic risk score, whether it's high or low? So first we did the study in European ancestry men. We looked at carriers, the odds of prostate cancer among carriers of these rare pathogenic variants. And on the x-axis here, we're showing the different PRS categories. And here you can see that the odds of prostate cancer among carriers does vary widely based on what the carrier's PRS is. And likewise, the odds in non-carriers also depends on what the PRS is. And in particular, you can see that men who are non-carriers with high PRS have odds of prostate cancer that are very similar to men who are carriers but have average polygenic risk scores. The absolute risk of prostate cancer by age 85 in carriers was about 26%, and it was about 11% in non-carriers. But you can see that those absolute risks actually have really wide ranges if you take into consideration polygenic risk scores. So non-carriers, they can range from about 2% up to about 30%. And in carriers, they can range from about 10% up to about 55%, depending on the polygenic risk score. We did similar studies in African ancestry men, and here we had a smaller sample size so that we used tertiles instead of deciles. But you can see a really similar figure where the odds of prostate cancer in carriers and in non-carriers depends on what the polygenic risk score is. And when we look at absolute risk of prostate cancer in carriers and incorporating polygenic risk scores, you can see that there's, again, a pretty wide variation in what those absolute risks are based on their polygenic risk score. And then last, that was looking at just overall prostate cancer risk, but if we look at lethal or metastatic prostate cancer, we see really similar pictures, but the absolute risk here are a little bit lower just because metastatic disease is not as common as overall prostate cancer. But again, the absolute risk of prostate cancer among carriers really depends on what their polygenic risk score is. So considering rare variants and carrier status in conjunction will likely improve predictive models. So in summary, I hope one of the main takeaways from this is that it's crucial to include diverse populations in genetic investigations. This can improve risk models across populations and uncover novel biology. This also enables the identification of population-specific variants. Genetics could potentially reduce health disparities through improved screening and disease management. We've shown that the multi-ancestry PRS is a valid predictor of prostate cancer, and there's some evidence of potential clinical utility. It's highly replicated across diverse populations, and it's predictive of risk of aggressive disease in African ancestry men and risk of upgrading. We also show that African ancestry-specific variants contribute to risk of aggressive disease, and that the influence of rare pathogenic variants on overall and aggressive prostate cancer varies by polygenic risk scores. So the next steps of these research are to further increase the diversity of participants included in GWAS so that we can improve polygenic risk scores and identify more population-specific variants, and to evaluate the clinical utility of polygenic risk scores in a clinical setting and across diverse populations. So I do want to give just a couple quick examples of other studies that are working on some of these questions. So there's the eMERGE study that's prospectively returning polygenic risk scores for 10 conditions, one of which is prostate cancer, and 25,000 diverse participants. And their goals are to assess patient understanding of genome-informed risk, the uptake of recommendations for disease management, and impact on clinical outcomes. Another study is the Genova trial that's also prospectively returning risk for polygenic risk scores for 5 different conditions, including prostate cancer. And here they'll assess the impact on clinical management, detection of undiagnosed cases, and primary care physicians' knowledge and beliefs on PRS. But for both of these studies, they're not really going to have very long-term follow-up to assess the ultimate outcomes that we really need to know, which are prostate cancer mortality. So there's a lot more work that needs to be done to really thoroughly assess polygenic risk scores in a clinical setting. And then last, I'll just mention that we're conducting a study in Washington to also evaluate some of these questions. And we're enrolling any non-white men who are diagnosed with prostate cancer across the state of Washington, which will hopefully be about 700 men per year, and their male relatives, whether or not they have prostate cancer, with the goal of being to follow these men who have prostate cancer to see if their prostate cancer progresses over time and if the genetic information that we collect is associated with risk of prostate cancer. And for the male relatives who don't have prostate cancer, to see if they end up developing prostate cancer and if genetics was associated with that. So we'll collect extensive information at each visit, which will occur every 2 years. And then these are some of the goals that I already briefly mentioned. But yeah, so that's all I have today. And I just want to thank you all so much for inviting me again and getting to talk to you and share this work with you. And I hope that this was of interest and that it sparks some good discussion.
Great. Thank you so much. Love to have some questions from residents before Josh. But maybe while the residents are thinking of a question, Josh, you can go.
Dr. Darst, thank you so much for your presentation. I look forward to meeting and speaking later today. My question is regarding actually region-specific data that you're generating. And I asked the question because actually in the state of Wisconsin, we actually, from the 2019 data, ranked 41st in the country for prostate cancer survival. And based on trends, we're likely going to be in the bottom 5 in the country. So I was wondering, yeah, absolutely the worst for prostate cancer survival. So I was wondering, with the data that you're generating, are there region-specific differences as well, in addition to because I've got my hypotheses that I expect that African-American men in Wisconsin are probably doing worse than even these national averages. So what are your thoughts on region-specific differences?
Yeah, that's a great question. I'm sure I think that's something that we probably need to look into and try to better understand to see like if that is something that's going to impact our results. One problem we have, I think that's similar to Wisconsin, is that there aren't that many Black men in Washington. It's kind of a homogeneous population, and that could potentially also impact care because they're underrepresented in the state and they're also underrepresented in clinical care providers. But yeah, I think that's a really great question and something that we should think about. And also something that could really impact even some upstream analyses, because it could change outcomes for those participants too. Yeah. Mm-hmm.
Okay, my question is a little bit different from your focus, but can you speak to the rate of screening of different populations, and how does the rate of screening for prostate cancer impact some of the healthcare disparities that we see?
Yeah, that's a good question. So I probably don't know everything about this, but I think it's a little bit interesting for prostate cancer because incidence rates are highest in Black men. Although you imagine that there could be some disparities where some Black men are not being screened and they should be screened. But the recommendations are that for Black men that they do receive screening because they're known to have increased risk. But it's kind of hard to know, how much under-screening is there in this population, and how much, if they were screened more, maybe these disparities would be even bigger than we already see, because the incidence rates, even with this potential for there to not be enough screening in Black men, they're still higher in Black men. So maybe that is actually a higher number than we are actually observing.
But I guess differences in screening rates could explain differences in mortality if disease is being picked up at a later stage, et cetera.
Yeah. Mm-hmm. Yeah, I think one of the things about for more aggressive prostate cancer is that Black men are more likely to be initially diagnosed with more aggressive prostate cancer And that could be because they just weren't screened early enough or at the time that they should have been screened. So I think that definitely will impact outcomes.
Another question. So you mentioned the shared risk factor of like BRCA2 and breast cancer, and both breast cancer and prostate cancer are hormonal responsive tumors. So are any of the genetic associations shared in common between breast and prostate? And can we learn across?
Yeah, that's a great question. So there are, in terms of rare variants, there is certainly shared genetic variation. You know, for example, BRCA2 and ATM and a lot of other really common cancer genes are shared between the two. And there is some genetic correlation also. Some studies have shown that there's genetic correlation between breast and prostate cancer. But I've actually gotten this question maybe the last 2 times that I've presented. People have asked the question of like, well, is the prostate cancer polygenic risk score also associated with risk of breast cancer? And I think that's a great question. So something that we'll have to look at and try to better understand, like, you know, how just to kind of disentangle a little bit and better understand the shared genetic architecture between the two. Yeah.
Thank you for an excellent talk. I'm wondering about the practical aspects of genetic testing in the clinic. How do you propose the PRS being implemented clinically? Is this something, this actually is a great question. I was thinking about the same. Is this something that everybody should get in primary care, or those who only have a family history of prostate cancer? And then how do you envision genetic counseling being incorporated into this workflow? And finally, who's going to pay for the test?
Yeah. Okay. I'll try to remember each of those things and respond to the ones that stuck out the most to me. So the question about family history, I don't think that genetic testing should be limited to men who are family history positive, because we know in our rare variant studies, we see a large proportion of men who are family history negative that carry these rare variants. And that could be because some men don't know their family history, or they don't know it accurately, or maybe their relatives didn't live long enough to develop prostate cancer. So family history alone is not enough to determine who should get genetic testing. I think that would actually end up excluding some men who would be really good candidates. How it would be implemented.
So should everybody then get screened?
Yeah, so I think I'm a little bit biased on this, and I'm not a clinician. I'm not a clinician, so I don't understand all the implications in terms of insurance and that. But I think one day it would be great for everyone to have all of their genetic information just on record, and like at some point in their life, their clinician can say, okay, like you have higher risk for this, so we'll start screening at this age. But I know there's a lot of like discrepancy. I don't know, a lot of people might not agree because there's some hesitation about knowing your genetic information or your genetic risk. You might have genetic risk for something that, you know, is really strongly environmentally driven. But we have done some studies in the past, a long time ago, like 10 years ago before I started grad school. I was involved in research where we returned genetic information to participants, and we did not see any increased anxiety among participants who had increased risk for some genetic diseases. And we also didn't see any change in behavior in participants who had increased genetic risk. So I think there's a lot of concern around maybe having anxiety, but I don't think there's evidence to show that patients actually do have anxiety in population-based studies, at least. I'm sure on an individual level basis that could vary a lot, but yeah, I know that could potentially introduce a lot of complications. And with insurance, you know, I'm not really sure how that would be handled or justified, but I think, you know, if some of these things could at least make it into the guidelines that, you know, for some specific variants that you get, that's just included the way that, you know, BRCA2 is included. I think that could at least help offset some of the insurance issues.
All right, thank you. We are out of time. Thank you all for your attention. And as I mentioned, we have an opportunity